all I ask is the task at hand is to discuss about various alignment philosophies as well as CPAK classification, so that as this becomes the foundation for the next 3 sessions. Okay, so let's go back to 1970, where 2 tenets for mechanical alignment were given by Dr. John Insall as well as Dr. Chit Ranawat. One is 90 degrees mechanical cut, 2 is an HK axis which is straight as 180 degrees. This gave us good pain relief, long-term survivorship, which is undeniable. Right at that time, Hungerford was coming up with his own philosophy where they leaned towards an anatomic alignment, which was much difficult to achieve. The instrumentation nor the implants were suitable for it, so it fell out of favor. So now 5 decades after that, it is very safe to say that mechanical alignment is still the gold standard. It is targeting equal compartment loads on both sides, and the survivorship that you can see is undeniable, 94 to 92% survivorship at 15 years. But it does beg the question, are you actually changing the anatomy, the biomechanics of these patients by targeting the same strategy or the alignment in all these patients? So here you can clearly see that when you do a 90-degree cut to both the femur as well as the tibia, you are distalizing the lateral joint line, elevating the medial joint line. So this creates a scenario of medial tightness as well as lateral laxity, for which you need to change, do releases on the medial side, and you are systematically changing the anatomy, laxity pattern, as well as knee kinematics of every single patient. Come 2010, a lot of researchers started realizing maybe this is not the only way surgery needs to be done. We need to recognize the fact that everybody has a different alignment, and even in the same patient you might have different alignments. A lot of credit goes to Stephen Howell as well as Johan Bellemans and a host of other researchers who came up with the concept of 1, kinematic alignment, 2, a native constitutional varus is common in most patients. So here Bellemans showed that at least on an average in the Caucasian population it is around 2 degrees of varus in healthy individuals. And Dr. Mulaji and the Japanese researchers came up with a number for the Asian population to be around 2 to 3 degrees of valgus. So if the knee is not 90 degrees to the ground, or if the overall HK axis is not 180 degrees, is there a different way of doing total knee replacement, was the question. So for that you need a particular classification system which can accommodate both for constitutional alignment as well as joint line orientation. So that's how this whole concept of phenotyping patients came in. Out of all the phenotype classifications, the one that has really caught on and gained traction is the CPAK classification, which is coronal plane alignment of the knee classification. Here, McDessie divided the knee phenotypes into 9 grids. This is based on 2 calculations. One is the arithmetic HKA and the other is joint line obliquity. And in the vertical slides, you can see that you either have constitutional varus, neutral, or constitutional valgus. This is based on the alignment. And based on the joint line obliquity, you either have apex distal, where the lines meet distally, neutral, or apex proximal. So how do you calculate the arithmetic HKA and the joint line obliquity? First, you need to understand the difference between mechanical HKA versus arithmetic HKA. Mechanical HKA is nothing but the angle between the mechanical axis of the femur and the tibia. Arithmetic HKA is different, which is the difference between the MPTA versus the LDFA. And here the main difference is, by calculating arithmetic HKA, you are completely negating the joint line congruency changes that can happen in patients as the deformity progresses. But it's also important to understand that CPAK classification is based on a setup where there is no bone loss, but as bone loss gets into the picture, then the numbers become little less reliable. So how do you calculate the arithmetic HKA? It is MPTA minus LDFA. If your value is neutral, which is 0, then you're categorized as neutral alignment. If your value is negative, then you are labeled as constitutional varus. And if your value is positive, you're labeled as constitutional valgus. Similarly, joint line obliquity is MPTA plus LDFA. If you're 180, it is known as neutral. If you're less than 180, it is known as apex distal because they are meeting distally. And if you're above 180, it is known as apex proximal. So that's how you get this grid. And in interest of the standard deviation, the ranges have been prescribed as -2 for constitutional varus and +2 for constitutional valgus. Similarly, anything less than 177 is known as apex distal, and anything more than 183 is known as apex proximal. So here is a case example of a patient where you've calculated the MPT and LDFA. 85 minus 89 is -4, which is constitutional varus because it is less than 2. And then 85 plus 89 is 174, which is less than 177, which gives you an apex distal joint line. So in this particular patient, if you add up the numbers, you have a situation where you have constitutional varus as well as apex distal joint line, which makes this a CPAK type 1. So this is how the classification happens. And on the left is what Megdesi reported in the Caucasian population. On the right is our study, which we published in 2021, where we have shown that instead of CPAK type 1, which is more common in the Caucasian population, we have more CPAK type 1 instead of 2. And our common types are 1, 4, as well as 2, which are showing that we have a lot of constitutional varus in our patients. This is a representation of ethnic variation of CPAK, and you can see that Asian populations like India as well as Japan have more CPAK type 1. Because of this reason, most of our research from now on is concentrated on CPAK type 1. And I think this is one of the most profound slides. You can see 5 knees which have varus. And if we completely remove phenotype from our system and we try to do mechanical alignment in all these patients, I think it's not the right thing to do. You can see here every knee has a different alignment and every knee has a different phenotype classification. So the effort right now with CPAK classification is, please understand, this is neither the start nor the finish. CPAK is actually a research tool which will help you to know what is the pathology right now, and at the end of surgery, where have you put the patient, so that we can do research and see which ones are working and which ones are not working. And one of the main limitations is, again, bone loss, and the sagittal and rotational aspects have not been considered in this particular classification. Alignments have to be divided into fixed as well as individualized. Fixed alignment is where you have the same target in every single knee, which is mechanical as well as anatomic. Or you should have individualized alignment targets, where I have already listed what these alignment targets are. Till 2006, I think life was happy when Stephen Howell really rocked the boat and started talking about kinematic alignment. And like how Dr. Ashok Rajgopal said, now you have a barrage of many alignment philosophies, but I will only concentrate on these 4 alignment philosophies in terms of introduction. Please understand, on the left of your screen, you have Dr. Insall, where most of your work in terms of balancing the knee comes from soft tissue releases because the alignment is 90-90. On the other end of the spectrum, you have Stephen Howell, where he recommends that most of the work needs to be done bony and none of the soft tissues need to be touched. So let us look at kinematic alignment first. The main issue with kinematic alignment or the philosophies, it is unrestricted, meaning they don't think of how much varus or valgus they're giving in the femur or the tibia. They don't touch the soft tissue. They accept whatever native laxity is there. And for them, the femur is sacrosanct because they don't want to move the alignment of the femur. Whatever adjustments need to be made are to be made on the tibia. So how did this philosophy come up? What Stephen Howell tried to prove is, if I do a resurfacing procedure, I will, and by cutting equal amount of bone from the distal as well as the posterior aspect of the tibia, I will recreate the flexion extension axis of the tibia, the patella, as well as internal and external rotation axis of the tibia over the femur. This he's done by cutting equal amount of bone from the posterior as well as the distal aspect and same amount of bone from the tibia. This is an example, and as I said, femur is sacrosanct, they don't move the femur. If some adjustments have to be made, they are made on the tibia. And this has caused a lot of concern. So here you can see that this is an example where I'm cutting 7 of the tibia, 6.5 of the femur, both posterior and as well as distal. At the end of this procedure, where you can see that as I'm balancing this knee, the knee is almost balanced in this particular case. and all that I have to do is raise the tibia by 3 millimeters and 1 degree of external rotation. I've balanced this knee. So I didn't touch the soft tissues in this particular case, but the caveat is I have to accept 8 degrees of varus, which is a hypothetical situation here. We didn't do that in this particular case because anything beyond 5 degrees, we are trying to stay away from it. Concerns of kinematic alignment are very clear. It is the extreme implant positioning which created a lot of flutter in 2006, but all credit to him. It is 16 years out now. There is no difference in survivorship between mechanical versus kinematic alignment. In order to obviate the disadvantages of kinematic alignment, which is unrestricted, Venditorelli came up with the concept of restricted kinematic alignment, where he recommended some boundaries because it was so wide, no surgeon was comfortable putting the knees in almost 8 degrees of varus. So what he said is individual implant positions can be within 5 degrees and the overall HKA axis should be between 3 degrees. And this is when there was a big uptick of people taking up restricted kinematic alignment. So this is the algorithm that he has proposed, but I think this is quite complicated for this time. So between kinematic and restricted kinematic, the difference is from unrestricted boundaries, you go to restricted boundaries. You still like native laxity, and you will still manipulate the tibia and not touch the femur. So that is the difference between these two strategies. That is what we did in this particular case. Instead of 8 degrees varus, we reduced it down to 5 degrees of varus. And you can see, because of doing that, I actually changed the phenotype. This is where CPAK is coming in. This is a research tool. If I had done kinematic alignment in this patient, I would have been CPAK type 1. Because I reduced the varus in my tibia, I've moved it to CPAK type 2. And now you have a good yard measure stick to see which one of these patients are actually doing well. So here you can see that I've induced tightness on my medial side because I reduced the gap, and then I had to do soft tissue releases in these patients. A quick word on inverse kinematic. It is exactly opposite to kinematic alignment, where de Graaf said, instead of moving the tibia, let us move the femur, because he was too worried about how much varus is being given on the tibia. So you can see the main difference between pure kinematic and inverse kinematic is, in pure kinematic, you manipulate the tibia. In inverse kinematic, you actually manipulate the femur. So here, inverse kinematic is a balanced philosophy, and then instead of moving the tibia, you're moving the femur. So let us come to what we are following. We are following functional alignment. This was a concept given by Faris Haddad in 2020, which is a balance-driven philosophy. Till now, you've heard of all alignment philosophies, but this is on the opposite side, it being a balance-driven philosophy. Here you can see, in this particular case, I have freedom of both moving the femur and the tibia in order to balance the knee. I'm doing this with least compromise to the soft tissues, and I'm letting balance drive my alignment. So here is the main difference, where you can see in functional alignment, balance drives the end result in terms of alignment. In kinematic and restricted kinematic, it is the opposite. Alignment is sacrosanct. Whatever resultant balance you get at the end of surgery, you accept. So that is the main difference. You can both move femur as well as the tibia. And here are two ways of doing functional alignment, one with a kinematic start point, one with a mechanical. I think I won't go into too much detail, but the main difference is, if you want to recreate obliquity in your joint line, use a kinematic start point versus a mechanical start point. So here is the final grade, where you can see functional alignment is restricted, balanced, and you can either move the femur or the tibia. There are multiple papers talking about all these alignments. The last two things I need to submit is, please understand, a malaligned and an ill-balanced knee is the one that fails. This is the one that we are all fearful of. If you natively align a knee based on some phenotype and you balance those knees well, there is enough evidence to show that these knees have survived even 20 years. So this is what we normally do now. We take a CPAK classification, we calculate all the MPTAs, LDFAs of our patients, we phenotype them. We are usually doing either CR or a CS. We use functional alignment with a KA start, and these are our boundaries and the laxity patterns. So the take-home message is, mechanical alignment is still the gold standard, but know that it is actually changing the biomechanics of the patient. If you want to embark on personalized alignment, the goal here is to create a native joint line as well as soft tissue laxity pattern, which is work in progress. And then CPAK is a research tool. You should know where you're starting, where you're ending, so that you can do significant research. Thank you.